So I'll just, because the time is short, I'll just quickly go through cases. Uh, so the people who are interested in cardiac MR and who have some basic knowledge, I'll just quickly go through some of the cases, beginning with the normal scan. I hope you can see my, uh, yes, the right. All right, so this is basically two-chamber view. The other one is four-chamber view. And this is the three-chamber view where you can see the blood moving from LA into LV and then going into the aorta. You can go see LVOT as well. So in MR, there is no radiation. There's no time limitation. You can get as many planes as possible. So this is primarily a cine white blood imaging. Not going to go into the detail of the physics, but this is primarily a cine imaging, where we play the loop and we can see the contractility of the myocardium, and we can also see the movement of the blood, whether there's any turbulence or any other problem. Then we go take a stack extending from the apex. So now we are taking the stack which is moving from the apex towards the base. So now we are bisecting the mid cavity. You can see some of the papillary muscles there. And then this is the right ventricle and this is the left ventricle. And we are basically looking for this figure of 8. The aorta is arising right from this part, so that we can plan our next slice. This is a black blood image. This is primarily inversion recovery. Just a small physics. It's an extra impulse, which is 180 degree. You have to get rid of the white blood signal from there so that you can get a good morphological assessment of the muscle of the LV and other areas as well. So this is T1, this is T2, this is T2 fat sat, or you can say stir image, and this is, you can also get into another plane. You can take short axis, you can take LVOT wherever the pathology is. So primarily this is for the edema imaging in patients with the MI, with patients with myocarditis, and all the inflammatory conditions which will render edema within the myocardium. This is followed by the perfusion scan. If you're running stress scan, usually we use adenosine in Pakistan. Regular adenosine is not available to my knowledge. So contrast, as you can see, we have injected gadolinium. It is coming from the right side to the left side, and then it is disseminating into the myocardium. So by adenosine injection, followed by the rest phase, you can see whether there is resting ischemia, whether there is reversible ischemia, or whether there is a fixed infarction. This is followed by LGE images. These are late gadolinium images where you can see scarring. So this is a normal myocardium on LG images, which is all jet black. You can see the white contrast within the lumen. This is a normal myocardium on the short axis view, taken at near the apex, mid cavity, as well as at near the base. Again, on two-chamber view, four-chamber view, and three-chamber view, you can take as many images, as many planes as possible within a certain frame, because the gadolinium is gonna fade away. Just to give you a rough idea that how you're going to differentiate based on the scar burden and where the scar is. So that is very important. So in the first slide, you can see the ischemic pattern. Mostly the white scar, this is the gadolinium, which is basically pooled in the scar in the infarcted tissue where it's necrosis. It's not letting go the contrast. This is the normal myocardium. So subendocardial and transmural ischemia, obviously, and non-ischemic patterns are all other patterns, like in mid-wall cavity. We can see it in the dilated cardiomyopathies, myocarditis. Then at the RV attachment site, this is HCM. Sarcoidosis, its favorite site is posterolateral wall. Then epicardial, it can be seen in, again, sarcoidosis, myocarditis, Anderson-Fabry, and global endocardial enhancement is basically seen in amyloidosis. We're going to, inshallah, go through all those cases. This is a very novel sort of a software, which is T1 mapping. It is very useful in patients where we cannot inject contrast, cases with amyloidosis where the renal function is also compromised, EGFR less than 30. We don't recommend giving contrast anymore. So the patients who come from the renal centers like PKLI, we then go for T1 mapping without injecting contrast. We get some idea that whether there is underlying infiltrative disease or not. So in this case, this is a case of myocarditis. You can see the T1 native. I hope you can see the light. T1 native value is is more than 1200, which is higher. So this was the case of myocarditis with edema. This is just a rough map where you can see that the higher values in the red codes, this is basically the domain of the amyloidosis. The higher the T1 value, without injecting contrast, you can see the domain where the TI value is high in MI, amyloidosis, chronic MI, acute myocarditis is somewhere in the middle, followed by the HCM and DCM. And then on the lower side where you can see the blue coding, this is low TI value where when the fat is there and when the iron is there, the T1 mapping also gets reduced to less than 900 milliseconds. Then we can also do pericardial tagging for patients with constrictive pericarditis. I'll show you the case, but just to get an idea, in the diastolic phase, we apply the strips and the grids, and you can see in the diastolic phases, the grids and the stripes are breaking up. So that means it is giving you a good diastolic phase. There is no underlying constrictive pathology. So it's very novel, hardly, I think, 10 seconds sequence. Iron quantification is very easy to perform. Again, I get a lot of patients with thalassemia. So we do simultaneous cardiac and liver imaging. Takes again a hardly 10-second sequence in which we can quantify and map out the iron. The red part is all iron. It is on the higher side. So it is more of a, you can see the focal deposition rather than a diffuse deposition. So these are multiple reference ranges in cardiac T2 star where the value is less than 10. We consider it as a very severe iron overload. And these are the patients which are definitely going for chelation therapy. Coming to the cases, first we are going to see the DCM. Here you can see a very slow moving heart. It is hardly moving. EF calculated was less than, I think, 15%. Here you can see that LV, and actually all the chambers are dilated. Underlying, there was ischemia. There's a case where there was no ischemia was found. Again, you can see dilated multi-chamber enlargement and the ejection fraction was less than 20%. Now, cardiac MR has become sort of a gold standard, but nothing is 100%, but it's very novel in that sense that the ejection fraction of the left side and on the right side, it's very easy to reproduce and it has low variance. Viability studies are very common. Here you can see that if you can appreciate that there's thinning of the interior wall and the apex as compared to the basal segments. Here you can see that it is hardly moving. It is very hypokinetic on two-chamber view. On LGE images, you can see scarring in the apex and we can see there is some black normal tissue there telling us that there is some viability in this LAD territory, whereas apex is there's a transmural involvement, so that means that it is gone. There's no viability in this area. So again, this is LAD territory infarct, and this is again the septum, which is subendocardial, not transmural, and there is some viability there, whereas the apex is somewhat transmural in this regard. It's very easy to, again, it says very low variance. Sorry? Asha, so I'll finish. No worries. I'll finish. So this is just how to do the viability scan. Thank you very much.